Hello, Aman. Welcome.
Hello, Anne. Thank you.
We're very glad you could join us. I'd just like to introduce Aman very quickly. He's a consultant ophthalmologist in practice. And when he was training at Moorfields Eye Hospital, he came and did his PhD with us between Moorfields and St. George's on dislocated lens in Marfan Syndrome. And in actual fact, he was very successful and found a new gene for dislocated lens. And this answered a question we've been asking for a long time. Do all our patients who have dislocated lenses also have Marfan? And the answer is no. So Aman knows the Marfan eye inside and out, and he's going to tell us all about it and mention ECTOPIA lentis genes as well. Aman?
Thank you, Anne, for that kind introduction, and the Marfan Trust for hosting this. I'm going to share my screen now, if that's okay. I'm going to do what we all do now, is confirm that you can see my screen. Is that good?
Yeah. Yes, we can see your screen.
Excellent. Well, thank you everyone for inviting me, and it's a real pleasure to talk about Marfan syndrome. As Anne mentioned, I've spent the best part of the last decade thinking about Marfan, the Marfan eye, and patients with this condition I find very interesting and very engaging, and I quite enjoy working with this condition. So I work in the Mid and South Essex Hospital, which is primarily Southend, and the Anglia Ruskin University, which is based in Chelmsford. So for those of you who aren't from the south of England, Essex is to the east of London, and those three circles are the geographic areas where I'm based. Chelmsford, Basildon, and Southend. You've probably done this already, but I can't give any talk on Marfan syndrome without tipping my hat to Antoine Marfan, who described Gabrielle, the 5-year-old girl on the right, with the skeletal features of what was later to be described as his condition. 1896, he described her, and we are here where we are primarily because of him. So there's a lot to talk about with the eye, and I'm going to skirt over all of it because in the limited time frame we've got, and then briefly describe some of the work we have done and continue to do in this condition. The eye in Marfan, I'll show you a picture of the eye, but I'm going to talk about the front of the eye, which is the cornea, retinal detachments, of course, dislocated lenses, which is called ectopia lentis, and myopia, which is short-sightedness. And with our work, I'll just talk about how common retinal detachments and ectopia lentis is in Marfan, and talk about some of the other genes associated with ectopia lentis, but not in a great deal of detail. I'll leave the scientific discussions to Jose later. And then, of course, any questions you might have. So this is a picture of the human eye. I'm going to assume you can see my mouse here. This is the front that you see when you look at someone's face. You might see a bit of the white of the eye. And the rest of all this is hidden in the eye socket, surrounded by bone. And if you open the eye up, inside the eye you have the retina, which is this red bit, and this bit here is called the optic nerve. And the center of the retina is this bit here called the macula. So the white bit is called the sclera, and the red bit is the retina. And at the front, the blue bit, if you've got blue eyes, is called the iris. The gap in the middle is the pupil, and behind that sits the lens. And what I've done here in red boxes, is basically every part of the eye that has fibrillin in it. And fibrillin, as you know, is the gene that's affected by Marfan syndrome. So as you can see, the eye is drowning in fibrillin, and therefore unsurprisingly affected by mutations that disrupt the protein fibrillin. I'm going to ignore most of the eye even though there's bits of fibrillin, and focus really on these four parts of the eye that have fibrillin in them: the sclera, the white bit, the cornea, which is the window on the front of the eye, the lens, of course, and then the vitreous and the retina, which is at the back and inside the eye. So the vitreous is the gel that lives inside the eyeball that composes about 80% of or 90% of the eye. Start at the front, the cornea. So the cornea is the bit you can touch, the bit you might put contact lenses on, the bit that hurts if you scratch it. So in Marfan syndrome, the cornea is recognized to be flatter and thinner than the normal population. This has been demonstrated over and over again. And that's a bit surprising because actually if you look at the cornea, which is the front of the eye, and sliced it in half, 90% of it actually is called the stroma, more than 90% of it. And yet fibrillin only occurs right in the top two layers. These are less than 10 microns in thickness. So with fibrillin only being at the very front of the cornea, it's a little bit surprising that the cornea is so dramatically affected, but it is. And in fact, it's so dramatically and consistently affected in terms of being flatter and thinner that some people have suggested that the corneal measurement should be considered a diagnostic criteria for Marfan syndrome. You will mostly be aware of the Ghent criteria that includes some eye features, but some people suggest that the corneal measurement should also be a diagnostic feature. And I think there's some merit in that. And maybe I'll touch on that a bit later on. But the question that we all get, all eye doctors who see patients with Marfan's, is, you know, should I have laser surgery? With laser corrective surgery, basically lasers the cornea and thins it out in certain parts of the cornea. So if the cornea of a patient with Marfan syndrome is already thinner than normal, one should not consider undergoing treatment that would then thin it further. So do not consider laser corrective surgery in a patient with Marfan syndrome if you have Marfan syndrome or someone you know does. That's briefly about the cornea. So now we'll move on to the back of the eye, the inside of the eye. So I will show you, I'll remind you again. So the white bit of the eye is the sclera, and inside of the eye is the layers, the choroid, and this is the retina here. And retinal detachment is thought to be more common in Marfan syndrome. And this was first described almost 40 years ago by Irene Montmagny as being a common condition. And yet the fibrillin is not actually within the retina. It's in the outside layers and within the gel inside the eye, but not in the retina. And I'll come back to this later, but retinal detachment is common in people, more common in people who are short-sighted, and people with Marfan syndrome are more short-sighted. So now we'll come to the lens, and I hope you're all with me, and I hope I haven't given you too much information so far. If you've got questions, please ask them and I'll answer them perhaps toward the end of the talk. So dislocated lenses, or as it's called in medicine or Latin, ECTOPIA lentis. Now, ECTOPIA lentis actually is the most, it doesn't mean Marfan syndrome, it just means dislocated lenses, and it can, of course, be caused by trauma. But the most common cause of it is Marfan syndrome, and it's so common that it's actually one of the major diagnostic criteria for diagnosing Marfan syndrome. And why is that? Well, I've got a cross-section of the eye at the bottom here, and the lens is held in place by little zonules, I describe it a bit like a trampoline. And those of you who know any children will know that everyone has trampolines and loves them. And the springs that hold the trampoline in place are a bit like the zonules that hold the lens in place. And those zonules are almost completely consistent to fibrillin at the expense of almost every other protein. And so therefore, when fibrillin is affected, those zonules become weak. When the zonules that hold the lens become weak, the lens shifts, and either can shift like this or can actually drop into the front or the back of the eye. Here we've got a picture on the right, and you can see these lines here. These are the zonules, and you can see what I mean, hopefully, by trampoline, the springs of the trampoline. And you can see they're missing here and broken here. And these being weakened and broken leads to this lens then not being held in place properly. There are certain mutations in fibrillin 1 that are more prone to cause ectopia lentis. And although we generally describe it being more common in the first couple of decades of life, actually people can become symptomatic at any age. And I've certainly had patients in their 30s, 40s, and 50s who suddenly become symptomatic with ectopic lens. And when they become symptomatic, if this lens shifts so far that it starts affecting their vision, then surgery may be indicated. Also, surgery may be indicated if the lens is causing, if the lens being displaced is causing damage to the eye, and then it therefore needs to be removed. if you do surgery, of course, on the lens and remove it, the eye now has no lens in place, and we need to replace that and adjust for that. I always recommend the first option, if not the only option or the best option if the patient can cope with it, is a contact lens, which sits, as those of you who wear contact lenses know, sits on the front of the eye, on the cornea. The beauty of the contact lens is it's removable, it's reversible, it's adjustable, and it's very safe. There's very little risk to using it, and there's no surgery involved. And I always put my patients through a trial of contact lenses in the first instance, because if they can cope with it, particularly young people, but if they can cope with it, it's a much safer process. Now, if that isn't an option, you can put artificial lenses into the eye, and there's a variety of places where you can put an artificial lens. You can put an artificial lens in what we call the anterior chamber, which is just in front of the iris, so just in front of the blue part of the eye if you've got blue eyes, or the brown part if you've got brown eyes like me. You can also put a lens attached to the iris, so attached to the blue part or the brown part. An artificial lens can be put in the normal position of the lens if you've managed to save the capsule that the lens sits in, that your normal lens sits in. So this lens becomes ectopic, but if you can save this bag, you may be able to put an artificial lens in place. This is not usually the case, because when these zonules, which are over here, become weak and the lens becomes shifted, this capsule becomes usually redundant. But some people try and save that capsule. This, for me, is the least favored option, although ideally it's the best for the eye, because I think it's the least favored because the zonules tend to become more and more weak as time goes by. So it becomes this artificial lens will then shift, and it becomes sort of a temporary measure, really. Alternatively, you can fix an artificial lens to the sclera, which, if you remember, is the white part of the eye, and that lens will then sit behind your iris, and that's a more natural position for an artificial lens. But there are, there's much literature on case series that describe where the lenses can be put. There are many options. There's no definitive evidence. We have not done any randomized control trials to really give us an answer. The reason being is because it's a small population, and you'd have to collect a large number of patients and randomize them appropriately. And I think there may be some merit in that, but I'll tell you that takes a lot of organizing and thinking about, and that hasn't been done yet. And it really is patient and surgeon specific. Patient specific, depending on the eye and the age of the eye in particular, the age of the patient and their demands. Surgeon specific, because the surgeon has to be comfortable with what they're doing. Right, so we've talked about the cornea and the lens and the vitreous. And now the white part of the eye, the sclera, which also contains fibrillin. So this leads to short-sightedness. It is the most common eye manifestation. So besides ectopia lentis, this is actually the most common manifestation in the eye of having Marfan syndrome. And that's because, as I said, the white part of the eye has fibrillin in it. When that becomes deficient, the eye becomes more stretchy, much like the skeletal system or the aortic root. When the eye becomes more stretchy, it becomes more long. And I don't think more long is a correct word, longer. And when you have a longer eye, that's what results in myopia or short-sightedness, because the focal point of images, instead of landing there on the retina, it lands in front of the retina instead of on the retina. So you can't see unless you put a corrective pair of lenses at the front of the eye. However, as you will all know, short-sightedness is very common amongst the non-Marfan population. It's ever increasing. In Singapore, 97% of university students are short-sighted. 97%. And this problem is ever increasing, primarily because of the environmental factors of urbanization. So when people spend their formative years indoors or looking at nearby things and not having outdoor stimulation, that does increase the risk of short-sightedness. And so therefore, in certain countries, as I say, in Singapore, for example, short-sightedness is almost pandemic. Whereas in other countries, such as Australia, where they have a much more outdoors lifestyle, it's not such a growing problem. So therefore, when it is such a common thing amongst the population, I do not think it should be part of the diagnostic criteria. For those of you who are involved or know about the diagnostic criteria for Marfan syndrome, there are major criteria and minor criteria, and the minor criteria include being short-sighted of more than 3 diopters sphere. This is, in my opinion, a nonsense thing, and because if you took my hospital at Southend in Chelmsford, at least 30% of people who are not Marfans will be short-sighted at that level. So it's a very, I think, an ugly or messy criteria to use and confusing. So I talked about the eye, and I'm going to talk a little bit about some of the work we've done. The first question is, how common are these problems? Well, the main problems, the visually threatening problems. Short-sightedness is not necessarily visually threatening because it can be corrected with glasses or contact lenses, but retinal detachments and dislocated lenses are common. That's what are visually threatening. So we did a survey many years ago, which we published 2013 now, which looked at how, and what we did is send questionnaires to members of the Marfan Association, 181 questionnaires, of which there were about an equivalent number of men and women. And we found almost a third of patients had ectopia lentis, and most of them were affected in both eyes. And 14% had retinal detachments. To put this into context, retinal detachments affects about 1 in 10,000 of the population. So it is more common in patients with Marfan syndrome, but almost half of them have been affected in both eyes. With regard to retinal detachments, we then wanted to look further and do a prospective review in the UK. And we used the British Ophthalmic Surveillance Unit, which is a recognized method of looking at rare conditions in the UK. And we looked at a year's worth of patients. So how this works is we send questionnaires to all ophthalmologists in the UK and question them about patients with retinal detachment and ask them if they had patients with Marfan syndrome. So over a year, there was 8 cases of retinal detachments in patients with Marfan syndrome in the United Kingdom, which is actually surprisingly low. And actually, we concluded that ectopia lentis is common, and that's not surprising. We sort of knew that anyway. But retinal detachments may not be as common as we believed, but when it is present, it may be more severe. The theories why retinal detachment may be more common than maybe the population is maybe patients with Marfan syndrome are more short-sighted, and also some of the surgery involved in removing lenses can sometimes put you at greater risk of developing a retinal detachment. I'll talk now a little bit about conditions that might cause ectopia lentis, which aren't caused by fibrillin. So dislocated lenses, as I've talked about extensively, is most common in Marfan syndrome, which is caused by FBN1 mutations or fibrillin1 mutations. And these patients will have skeletal and cardiac issues. There is thought to be a condition called isolated ectopia lentis, which is also caused by mutations in the same gene in patients who do not have cardiac and skeletal features. We've also demonstrated actually that patients who are traditionally might be called isolated ectopia lentis with fibrillin mutations, actually some of them then will be defined as Marfan syndrome based on their mutation. So we don't think that this terminology should really exist, because those patients who have fibrillin1 mutations can then develop cardiac problems in the future. So they shouldn't be labeled as not Marfans. They should be surveyed and monitored as if they had Marfan syndrome. However, there is a subset of patients who develop dislocated lenses who do not have mutations in fibrillin, and they will actually, most of them have mutations in this gene here called ADAMTSL4. Actually, we discovered a few other genes of the same family that can cause ectopia lentis, but this is the most common non-Marfan gene to cause mutations. And what we wanted to do is compare patients with Marfan syndrome and mutations in this other gene. And we found that actually patients with Marfan syndrome have a less severe form of ectopia lentis than people with this mutation. People with this mutation are affected at a younger age, and their ectopia lentis is generally more severe than patients with Marfan syndrome. But fortunately for these patients, we don't believe that they have any cardiac or skeletal problems. So although their eyes are worse, they don't have as severe or any systemic features that are associated with Marfan syndrome. I was going to show you some videos on ectopia lentis, but I'm going to skip through those because I believe they might be a bit gruesome. But if anyone wants to see them, well, we can. But I'm going to avoid them at the moment. So some questions that I always get asked, and of course, if this answers your questions, that's great. If not, we're more than open to more questions. Should I have laser refractive surgery? As I've said, and as you'll probably know, people with Marfan syndrome tend to be short-sighted. And most short-sighted people in the world are eligible to have laser corrective surgery so that they don't have to wear glasses. Should I have laser corrective surgery if I have Marfan syndrome? I hope I've clarified that earlier. The short answer is no, and the long answer is no. If I have to have my lenses removed, as in for dislocated lenses, where should I have, what kind of artificial lenses should I have placed? As I've said, contact lenses are the first and best choice, but if they're not suitable, there are many options for an artificial lens in the eye. They are surgeon and patient specific, and as yet, there's no simple answer. Contact sports. On the whole, contact spots are okay for your eyes. If you've got ectopia lentis, that probably needs to be discussed with a doctor. Traditionally, people would say you should avoid contact sports because there's a risk of retinal detachment. There's no firm evidence for that. I'd suggest perhaps if you're very short-sighted, certain sports such as boxing and rugby should be avoided, or at least considered not to be played because of the regular head injury. But then, you know, boxing I'll probably avoid for all humans, but that's a personal discussion. Children, should they have surgery for ectopia lentis? Well, if they've got ectopia lentis, they should be seen by an ophthalmologist. And if the lens is becoming problematic for the child, they probably ought to have surgery for it. But that's a very specific problem that needs to be discussed on an individual basis. That's the end of my talk today. I'm very happy to answer any questions or have any discussions from anyone involved.
Thank you very, very much, Aman. Can I lead with one quick question, and then Victoria has quite a few from the audience. Just to say, if a child is going to have their lenses removed, I thought it was possibly best to have them removed not early on in childhood, but wait until the eye is almost finished growing at age 10. Is that still true?
I know that's not the case, because it all depends on whether the dislocated lens is affecting the vision, of course. You can develop what's known as amblyopia, or a lazy eye, if you are not stimulating that eye. So lots of people have a lazy eye where one eye doesn't work as well as the other one, and that's caused by one eye not being stimulated. And that develops by the age of 10. So if your dislocated lens is affecting your vision as a child, it's better to have that lens removed and rehabilitate the vision in that eye as soon as it's feasible possible. With regard to the eye developing, that may influence whether you put an artificial lens in the eye. But removing the lens, the dislocated lens that's causing trouble, should be done as soon as it becomes a problem, because then you can still put a contact lens on the eye to help the eye see. So actually before the age of 10 is better, and probably sooner rather than later.
Thank you for that. Victoria, over to you.
An anxious mother wrote in, her 17-year-old son, he's now 17, he had a lensectomy 10 years ago, which has resulted in increased pressure within the eye, 26/32. He's now on lifelong drops. What is the long-term prognosis?
It depends on what the cause of the high pressure is, but as long as the pressure is kept under control by whatever means, be it laser or drops or surgery, that will reduce the risk of further damage. So really the pressure, the number that measures, that is a reflection of the pressure in the eye, needs to be kept under control. So that, if that is under control, the prognosis is good.
Excellent, thank you. She'll be happy. Then a lady wants to know about cataract surgery, when this would be appropriate. Are there associated complications with cataract surgery when no dislocation is present, just short-sightedness and astigmatism?
Yeah, not really. The zonules may well still be a little bit weak, even if there's no dislocated lens. But I've done a number of patients who've got Marfan syndrome whose lenses are not dislocated, and that's fine. really, cataract surgery should only be undertaken when the vision in the eye is affecting the patient's quality of life. Just because someone has a cataract, it doesn't mean they need to have surgery. Cataracts are like wrinkles. They're like grey hair. We all get them eventually. And just because you've got grey hair doesn't mean you have to have it coloured. And you only do it if it bothers you. In the same way with cataracts, only if it's affecting your vision sufficiently that it's affecting your quality of life should you consider having cataract surgery. And that applies to everyone, not just Marfan's people. That's for all patients or all people. There'll be a number of people on this Zoom webinar who have cataracts, and doesn't mean they have to have surgery.
Excellent. And Robin would like to know, his son's had both lenses removed. When discussing with Mr. Henderson at Great Ormond Street about the implantation of artificial lenses, the feeling was it was too risky because of the softness of the tissue in the eye that made fixing the lens in position unreliable. Could you comment on that, please?
Yeah. So how old is the person? Did they say?
14.
1-4.
1-4.
Yeah. Look, I think it's a reasonable concern about fixing the eye in a Marfan's patient. If the patient can manage with contact lenses, as I've said, that's probably the best and safest for the reasons I've described. It's reversible, it's adaptable, and there's no surgery. Fixing the lenses in the eye, there'll be a number of ways of doing it, and it is potentially more challenging in patients with Marfan syndrome. Children are a different category further, and I think it's reasonable to be cautious with it. And Rob Henderson is a pediatric retinal surgeon. I think, and I know Mr. Henderson well, and I tend to agree with his caution as to putting a lens in a child with Marfan syndrome, particularly in their development. And if they can cope with contact lenses, I'd recommend it.
Bridget would like to know how to measure the thickness of a cornea. Is it something she should ask her optician to measure, if possible?
I think there's no harm in doing it. Yes, opticians may or may not have the equipment to do it, but if you see an ophthalmologist, they will be able to do it. Some opticians will have the machines to do it. What does it really add? It doesn't really add much, but you can know, if you want to know your thickness, at least you're informed, and your optician can give you that figure. And if you like to have information, which I would, I think it's reasonable to ask the optician if they could give it to you. They may not have the equipment to do it. How is it measured? It's measured with a little instrument that touches the eye for about 3 or 4 seconds. But you put some drops on the eye to numb it, and it's a very, very straightforward thing to be done.
Thank you. Felix would like to know the criteria for lens replacement surgery. He's been correcting his vision with contact lenses, but it's never quite right. How bad would vision need to be to justify replacement surgery?
So if the best the criteria for having a replacement lens really is patients are not able to cope with a contact lens. So the vision that you will be able to get with a contact lens is generally the best vision you will be able to get, apart from perhaps the fluctuation. But when we measure the vision with a contact lens, that is as good as you will probably get with an artificial lens. So the vision not being good with a contact lens is not a criteria to then go and have surgery for a replacement lens. The criteria to have surgery with a replacement lens is because the patient cannot cope with contact lenses on a daily basis. So not about the vision, because actually the surgery for lens replacement can be quite tricky, and you may get fluctuations with that. But if you can cope with the contact lens, that's going to be probably as good as the vision will be.
Thank you very much, Aman. I'm sure there may be other questions, but if you can send them in to Victoria or to us online at info@marfantrust.org, we'll make sure they're all answered after the conference. Thank you very much, Aman.